Vitality.
Vitality Unfiltered.
Unfiltered.
With David Bauder.
Welcome back to another episode of Vitality Unfiltered. I'm David Bauder, your host. Joining me today from Weight Loss and Vitality is Dr. Christopher Reeves, Medical Director, and Nurse Practitioner Stephanie Lattimore from the Washington, D.C. Clinic. Today's conversation is going to be centered around synthetic and bioidentical hormones. Bioidentical hormone, the word bioidentical, it's everywhere. People automatically think that bioidentical hormone is safe, synthetic is not. Or there's a lot of misinformation out there. A lot of this is being projected on social media. So we want to really kind of take it to a real high level here and talk it so the audience can understand that, yes, there's a lot of thought out there that bioidentical hormone is a safer alternative. However, there are still risks associated with all of this, and that's what we're going to work on today in this conversation. So, Ms. Stephanie, real high level here. What is the difference between bioidentical and synthetics?
When it comes to hormone therapy, we have your bioidentical hormones and your synthetic hormones, and there's pros and cons to both. Synthetic is going to be similar to what we naturally have in our body. Bioidentical is going to be a literal biologically identical match to the hormones in our body. So you can think of this as structure and shape will bind to those receptors just identically versus synthetic. They're not going to bind quite as identically, but they may still be able to get the job done. So they differ on a molecular level. And like I said, there's pros and cons to both. When it comes down to it, though, we're trying to get the best match to the hormones that our body naturally produces.
Yes, and exactly. It can bind exactly the same, but after that hormone breaks down, it might not look the same as when a bioidentical hormone breaks down. So is that correct? Like the molecular structure component.
Right. So the bioidentical, as Stephanie said, is as close of a match to the naturally occurring form as possible. Synthetics are kind of like the pharmaceutical industry's one size fits all, kind of primarily driven by, being able to mass produce these and kind of cover a population. When I was in medical school, one of my mentors said to me, he was like, Chris, whenever a new drug comes out on the market, never prescribe it within the first 2-3 years of it being on the market, because that's when you're going to see all the side effects. Because what's happened is they've done a small study with a small subset of people, and they see some side effects that may come out. But when you apply that to millions of people, you're going to tease out those more rare, those 1 in 1,000, 1 in 10,000 kind of side effects are going to come out. And that's kind of a similar way to look at kind of like the synthetics. They were mass produced. And so when you see some of these side effects, a lot of that happens, when you talk about the breakdown, like you're talking about, of these compounds, the metabolites or the breakdown products of those hormones can sometimes be different than what the body would normally produce when it's broken down. And those metabolites may cause some side effects and some problems. And so that's just a deeper level of looking at kind of the difference between bioidentical and synthetic.
When you mentioned the story about don't be the first ones to prescribe a new medication, I immediately thought of Seldane, the antihistamine that got taken off, Fin.
Yes.
Right, that was enough. And I think Ketec. That was a macrolide that caused a lot of, I think, heart problems associated with that. And gosh, did we use the heck out of that a lot for like upper respiratory infections and things like that. And that came on the market with just like boom, and then like just like that, it was gone.
It come right back off.
Yeah, that's right.
Vioxx.
That's another one. Yeah, Vioxx was a big one actually. Vioxx. Good point on that. When this synthetic bioidentical hormone controversy really started in the Women's Initiative study, we've mentioned this on other episodes. And what we pulled out on that, and what the conversation is that Women's Health Initiative study that was done, they treated all the women the same. They used synthetics. They didn't use bioidenticals. And then they pulled the study. I mean, you have a lot of insight in that Women's Health Initiative. I mean, what are your thoughts on that?
Well, again, there's so many things that were done like on that, and that scared a generation of doctors from hormone replacement therapy for a whole generation. I mean, I was part of that training lull where everybody was avoiding it because the information in terms of how the study was done, when they re-looked at the data, they saw that everybody was lumped into the same category with, perimenopausal women in their 40s all the way up to their 60s and 70s. And they saw an increase in cancers and cardiovascular risk, but they did not separate these groups of women to see that if you were within 10 years of your onset of your menopausal symptoms, hormone replacement was actually protective as compared to detrimental. And as we know, as we age, incidence of heart disease, cancer, these kind of things occur independent of hormone status just with age. And so those data is kind of, that study kind of muddied the waters a little bit in terms of interpreting this. In addition to what we mentioned before, the use of synthetics as compared to bioidentical gave another different risk profile.
It really, really shaped the narrative on women's hormones. I mean, how it really got into the media hype, and it ran with it, and it just shut down an entire I mean, it's just crazy how it just really grabbed.
A whole generation of women are suffering unnecessarily, from a cardioprotective standpoint for longevity and vitality and wellness, but also in terms of symptomatic, in terms of moods and hot sweats and sleep disturbances and irritability, loss of libido, which can affect marriage and happiness. So it's so many things that are affected by such a way to be managed that can be managed.
Yeah.
And another generation is impacted by those women. They're fearful of hormone replacement therapy, and they've heard the worst of the worst, and they don't know how to proceed.
Yeah.
When you think of the patient population coming into our clinic too, there's just such a huge group of women, 59 to 65 that I see, just such a large portion, and they're all struggling with weight, but they were all left off of hormone therapy after menopause, every one of them. And they went through that whole phase, and they remember it very well. And they also are free to, they freely admit that that's when their weight became very difficult to manage, and they just were left off of that. So when you think about hormone therapy, whether it's bioidentical hormones or synthetic stuff, what do you, when you think about the metabolism and the downstream effect of how this stuff breaks down in the body, and kind of where are we trying to separate these two things?
So like I had mentioned, pros and cons to bioidentical and synthetic. The bioidentical hormones are going to be read by the body as same. So structurally same to the hormones that we already have. So they're going to break down a little bit more similarly to the hormones that our body naturally produces. The synthetic hormones are going to break down and hopefully improve some of the symptoms of menopause or whatever we're using them for. But there will be the formation of metabolites or kind of byproducts because they're not structurally identical. And there can be side effects from these metabolites that are produced in the body, sometimes unintended effects, not quite exactly the symptom management that we're going for. So that's kind of the downside of the synthetic hormones.
Yeah. And it seems like if there is going to be any long-term, well, that leads us to our next question, talking about what does modern hormone therapy look like, or what does hormone therapy look like in women in the next 10 years? And it's going to be, I just think about all of the work that goes into treating a single patient. And the tests, the follow-ups, the orders, getting the dose right, getting the preparation right, whether it's going to be a patch or, what do you think the modern hormone therapy is going to look like in women?
Well, I think that as we get more awareness and understanding of that this is not a scary thing, that it can be done safely, we'll begin to get more patients coming in that are seeking help with these symptoms and things that they're experiencing and they're having. One of the things that kind of naturally occurs is that's why having the understanding of the bioidentical, because there's different types of estrogen that the body makes, and they peak and valley at different times. Without getting too technical, like we talked about, E2 is the most prominent form of estrogen that that the women make from their ovaries, and during menopause those levels decline, and some of the other forms kind of throw out of balance, the proportion or the balance that is kept in check. And so some of the more detrimental ones that have the side effects and that sort of thing come out of proportion. So when you look at the bioidentical hormone replacements, we're looking at increasing the number of the quote unquote safer or more tolerated forms of estrogen to get that proper balance back. And I think that once we do this more, get more experience with this, I can't say that traditional medicine will be able to kind of do it effectively because the monitoring needs to be a little bit more close. This is kind of a recurring theme on the show, that in traditional medicine is not necessarily set up or equipped to really properly manage these women, because you need to do follow-ups within 3 to 6 months, not 6 to 12 months to properly make sure that you're on par with things. So that's where I think there can be a little bit of a struggle there, depending upon where you're seeking the care for their hormone replacement.
Yeah, I just see such a long-term, like tooth to tail, like long-term approach on managing women. It's just it's going to be such a customized approach for each single patient. It's not just you're just prescribing a medication to control someone's cholesterol level, or here's a blood pressure medication. Take this once a day. It's different. The current guidelines that are out there exclude so many women from even getting hormone therapy.
You said about the future. I think that you made a really good point. I think that I don't want to gloss over it. Is the rise and the advent of genetic testing and screening is going to be absolutely monumental in terms of teasing out this gray area that it's not black and white, but really laying in this gray area where you lie. So for example, depending upon your genetic screening, you may find that, a transdermal form is better than an oral form, or you may want this, an E3 heavy, E2 light version versus an E2 versus E3. So these are things that we're going to start to get more data, more information as we start doing more of this genetic screening and testing. And I think the future will allow for this precision medicine type approach for hormone replacement to safely administer these patients in those ones that traditionally today would be kind of excluded.
Yeah, 100%. They'd be excluded from anyone because no one's going to take, first of all, there is no processes in place to manage them.
Right.
It's just like, it is literally black and white. No, yes. Okay, you have these 5 things. No, you can't have it. You got these things. You're good. Oh, you can have it. Here's a patch. I mean, this is what we got right now in medicine.
And you said that the intake is time consuming. It really is. I had a new patient last week who came in for hormone replacement therapy. We talked for 90 minutes. I was very lucky to have that much time in my practice. She had been, and this will kind of help with the synthetic bioidentical mind frame, she had been prescribed an estrogen patch E2 synthetic from her OBGYN and 100 milligrams of progesterone. We checked her labs. They were decent for postmenopausal. They were not optimized by any means, and her symptomology followed the same pattern. She was feeling better postmenopause, but not quite. I think there was room to grow. There was improvement to be made. I offered her switching that estrogen, that E2 synthetic, because she did have some side effects, to an E2, E3 combination of bioestrogen cream. This was something that I could tailor to her. She'd get some of those benefits of the weaker E3 with less of the side effects. So she was willing to give it a try. So I will now assess her in 6 to 8 weeks to see if we've kind of moved the mark on her symptoms as well as in her lab work. And I increased her progesterone because she wasn't sleeping well. So that was kind of but that's just kind of a comparison of the synthetic can only be tailored so uniquely to a patient versus the room that we can make with bioidentical.
When you think about when these patients that you're seeing, how do you go about informing the patients of the risks associated with the hormones?
So definitely the intake is a big piece of it, that family history. I have a list of absolute contraindications, which I take with a grain of salt, but it's really important to take that history and pair it with routine screening. Have they had a routine mammogram? Have they had a baseline pelvic ultrasound? Family history, we're always going to dig up some distant aunts and, extended family members, but I want to know you, your mom, your grandmother, and I always ask if they have daughters as well. A lot of my patients have had genetic testing, so they know, I had a distant aunt with a breast cancer. We're not BRCA. We're not, it's not a hormonally driven cancer. So patients are well educated. They're savvy. They come and they know what they want, what they need. They make for great candidates. And there's always those screening tools I can use for women who don't know their family history as well. Every woman is going to have the same basic lab testing and screening to increase safety and to minimize risk. So
I wish that the BRCA test would be cheaper. Insurance really gives the patients a runaround on getting it approved through the insurance, and I think the cash price is right at $1,400 to get the comprehensive one, and it should just be open. It should just be open season. I mean, I'm not kidding. This should be like just somebody needs to come online and say this is a $150 lab test, and it should just be open for everybody.
Do you know how many women would jump on that?
Oh, absolutely, 100%.
I would.
Yeah, absolutely. There is an online BRCA testing business that does it, but they don't do the comprehensive one. They just do. I think they're just doing BRCA1, and it's not so terribly bad. But you still need. I think you still need
the whole profile.
If you're going to do this correctly. When you're working up when you're working up somebody for hormone therapy, like what is the process for you when it comes to blood work? Like, what do you normally do?
So I'll definitely do a full panel, complete blood count, metabolic panel. I always like to check liver and kidney function. Cholesterol is a big piece for women entering menopause. A lot of times their cholesterol can go up. Hemoglobin A1C. These are my basic screenings. But the 3 primary hormones I test for all women are that estradiol, the primary estrogen, progesterone, and testosterone. Can't forget about testosterone. A lot of times I'll check a sex hormone binding globulin, free testosterone. Those are the big ones that I'll check. Did I miss any?
Thyroid.
Oh, always. Oh, yeah. Oh, the biggest one. You guys are like, is she going to say it? Is she going to say it? Thyroid stimulating hormone and probably the whole panel. Mm-hmm. You can't ignore the. We talked in an earlier episode about how women, especially aging women, are at a 8-fold increased risk of developing a thyroid condition as well as an autoimmune condition. So weight gain, menopause symptoms should raise alarm bells on hypothyroid. So. That's in my.
Do you routinely check cortisol levels in the Dutch test?
I do not.
No.
I don't. We talked about adding it to our panel. Mm-hmm. Cortisol, as we discussed in the earlier episode, really needs to be tracked throughout the day. Mm-hmm. A single number, morning, night, it doesn't really tell us as much as a 24-hour would.
That Dutch test is something else. I mean, there's some good. That's a good test. I mean, there's no doubt about it.
Tell me about, is that the urine test?
Yes, it's a urine test, a dried urine test that you take. And that gives you kind of like, we're talking about that curve for cortisol. It tells you exactly where your peaks and your valleys are, and your basal levels and that sort of thing. Gives you an indication of those things. And given all that we're talking about, how cortisol affects everything and including the symptoms we're talking about here, I think that maybe we should. When I was preparing for that lecture, I was like, well, maybe we should do more Dutch tests.
Yeah, when I explored it, originally when the whole formulation of the protocols and things like that were being established, this was talked about a little bit, and it's an expensive test. Yeah, it's not a cheap one. Yeah, and even already when we're testing patients, and we're trying to go through it by the numbers and do it the right way. It all adds up, and it really came down to not very many patients wanted to pay the extra for the Dutch test.
And that's the problem with some of this stuff, is that in order to get the real answers and the real data that we need to really personalize and treat these patients as they need to be treated, insurance unfortunately is not going to cover a lot of these lab tests.
That's right. And that's actually, we're going to probably cover that. And one of our episodes we're going to talk about is a laboratory testing over 35. Mm-hmm. And I'm sure we're going to get into that on that conversation.
And you just made me think of something else, Dr. Reeves. Synthetic versus bioidentical. Synthetic might be covered by insurance, able to
might not.
Pick up at a retail pharmacy. Bioidentical, maybe not.
Yeah, not very many.
Yeah, so that's a pros and cons. We think of all the benefits of one, but ease of access, systems, this is a big theme.
Absolutely, across the board for all our patients. Yeah, I think that's, I really appreciate you guys' time today. And just for the listeners out there, just always understand, hormones aren't dangerous, misinformation is. And make sure you're doing your research. Make sure you get a credible, qualified, competent clinician provider that can help walk you through this. Somebody that's going to take their time and do an appropriate workup for you, explain the nuances of all of these different things that are involved with synthetic and bioidentical hormones. Synthetic hormones could certainly work very well for some certain patients out there. Bioidentical hormones from a compounding pharmacy could work perhaps better for another patient. And so with that, I want to thank you all for listening. If you enjoyed the show, make sure you click the subscribe button below. It really helps us out. And we'll see you next time on the next episode.
Thanks for joining us on Vitality Unfiltered with David Bauder. Addressing norms, busting myths, and uncovering health realities for a more vibrant life today. For more expert insights and real talk, make sure to subscribe and join us next time.